Good evening all. Today we'll discuss the WHO 2025 consolidated guideline regarding postpartum prevention, diagnosis, management of postpartum hemorrhage, and the recommendation we'll discuss today. What are the recommendation? The first is the context is antenatal interventions to prevent postpartum hemorrhage. Okay, so antenatal hemorrhage to prevent postpartum hemorrhage, there also be a full blood counts testing. Full blood count testing is the recommendations for diagnosis of anemia in pregnancy. In setting where full blood count testing is not available, you have to do a on-site hemoglobin testing with hemoglobinometry is recommended over the use of the hemoglobin color scale as the method of diagnosis anemia. Second is to prevent anemia in pregnancy, daily oral iron and folic acid supplement is 30 to 60 milligram. Elemental iron 400 microgram, that is 0.4 mg folic acid is recommended for pregnant women to prevent maternal anemia, puerperal sepsis and preterm birth and low birth weight. Sometimes those are not acceptable due to side effect of iron. You have to give intermittent oral iron folic acid supplement, that is weekly. Once a weekly supplementation, but the dose is slightly raised, that is 120 mg oral elemental irons and 2800 microgram, that is 2.8 mg folic acid once weekly is recommended for pregnant women to improve maternal and neonatal outcome if daily iron is not acceptable due to side effect and in population with anemia prevalence is less than 20%. The role of intravenous iron therapy is recommended for over oral those patients who cannot be used or not tolerated, or there is clinical need to correct rapid corrections. Provide women can be monitored, prompt reduction anaphylaxis has to be monitored properly. Then intrapartum interventions to prevent postpartum hemorrhage for women in second stage labor. Technique to reduce perineal trauma has to be focused. Facilitate the spontaneous preterm birth, include perineal massage. You have to do perineal massage, warm compressions, hands-on guiding on the perineum to prevent perineal trauma. Okay, routine liberal use is not recommended at all during spontaneous vaginal birth. Then postpartum intervention to prevent postpartum hemorrhage. The use of quality assured uterotoning has been recommended for the during prevention of postpartum hemorrhage during third stage labor. To effectively prevent postpartum hemorrhage, only one of the uterotonic should be used, that is either oxytocins. Only one, very important statement here. Either oxytocin or either carbetocins or either misoprostol. Only one of the following, not anyone. Only one of the following should be used: oxytocin, carbetocin, or misoprostol. This is the first line treatment to prevent postpartum hemorrhage. In oxytocin, or intramuscularly or intravenously recommended need for the prevention of postpartum hemorrhage for all birth. Carbetocin intramuscular or intravenously is recommended for the postpartum. So the heat stable carbetocin formulation is recommended where cold chain cannot be guaranteed. Misoprostol dose is 400 to 600 gram. Orally is recommended. Oral route has to be given. In situations where women give birth vaginally, already have IV access, intravenous administration 10 units. Intravenous administered 10 unit oxytocin diluted administered slowly over 1 to 2 minutes recommended. In prevention through intramuscular administration. Uterotonic is not recommended. Options are not recommended for prevention of postpartum hemorrhage include like ergometrines. For prevention, don't use the ergometrine, don't use methyl ergometrine, fixed dose combinations of oxytocin and ergometrines, and injectable prostaglandin. These are the drugs for the treatment. Ergometrine not recommended, or methyl ergometrine not recommended for the prevention of postpartum hemorrhage. These are the not recommended for preventions. Fixed dose combination oxytocin ergometrine 5 internals 500 microgram intramuscular not recommended. Injectable prostaglandin like carbopros, sulfoprostones are not recommended for preventions. Okay. The next is in setting where multiple uterotonics is available, only oxytocin is intramuscular is recommended choice for prevention of birth. Okay. Very important. If you don't have a oxytocin's cold chain, if oxytocin cold chain cannot consistently maintain, that case you have to use, very important, that case you have to use heat stable oxcarbetocin, that is 100 microgram intramuscularly or intravenously is the recommended of choice for the prevention of postpartum hemorrhage in setting where the oxytocin cold chain cannot be maintained. That situations cannot be maintained properly. That situation you have to use heat stable carbetocin, standard micrograms. Okay, or you can use misoprostol 400 to 600 orally as an alternative. Okay, next is the administration of misoprostol 400 to 600 orally by community health care is recommended for prevention of postpartum hemorrhage who are skilled not present administer injectable. Suppose you don't have a skilled wards, they will not able to injectable in administer the injectable. That case you have to administer oral misoprostol 400 or 600. In setting where women give birth outside health facility, strategy has to be maintained to distributions of misoprostol. Very important guidelines now this come that they have to distribute those area they don't have a absence skilled health personnel, or they have a health facilities very far away. In that case you have to distribute misoprostol antenatally for self administration for recommended for the prevention of postpartum hemorrhage only within the target monitoring evaluations. The tranexamic acid is not used in prevention management. Tranexa is not for prevention. Very important statement. Is only for treatment part. Tranexa is not recommended for the prevention of postpartum hemorrhage, whether it is vaginal part, whether it is cesarean, not at all indicated for prevention. Tranexa is not for prevention. In setting where skilled birth attendants available, control contractions is recommended. If they don't have any skilled birth attendant, then control contraction is not recommended at all. If based on the skill birth attendant, you have to go for a control contraction or not. If don't have a skill bar, then don't do control contractions. Okay, if healthcare providers small reduction bladders, very important statement. In cesarean section there is no need of control contraction, you have to do contraction. Very important statement. No need of control contractions prevent to removal of the placenta in cesarean sections. Then early cord clampings is the less than 1 minute after birth is not recommended unless, very important, unless there is a neonatal asphyxiation, need to be moved immediately for resuscitations. Then sustained uterine massage, very important. Uterine massage is not recommended for prevention. It is used for treatment part to prevent position in women who receive already. If they have received prophylactic oxygen, no need to do uterine massage for prevention. Okay. Next is your diagnosis of postpartum hemorrhage for all women giving birth. Routine objective measurement postpartum blood loss is recommended to improve detections of prompt postpartum hemorrhage. So diagnosis for all women giving birth, routine objective measurement like blood loss has to be done, like calibrated drifts per woman having vaginal birth you have to use. Suppose to identify women at risk for adverse outcomes, that is recommended to use the following criteria. Very important criteria you have to remember. Objectively measure blood loss threshold, that is more than 300 ml with any abnormal hemodynamic sign like pulse more than 100 beats, shock index more than 1, systolic blood pressure less than 100 mm Hg, and diastolic is less than 60. If any blood loss less more than 300 ml with plus signs of heart rate more than 100, shock index more than 1, pressure is less than 100, diastolic pressure is less than 60, and or any blood loss more than 500, whichever after within the first 24, you have to more vigilant within the first 2 hours. The tone of assessment for early identification has to be recommended. Then first response treatment is intervention. Oxytocin is the treatment. Now we are going to read the treatment part. Previously we taught about prevention. For treatment you have to use intravenous oxytocin recommended uterine drug to postpartum hemorrhage. If intravenous oxytocin is unavailable or if the bleeding doesn't respond, then ergometrin, IV ergometrin or oxytocin or ergometrin fixed dose combination or prostaglandin. Here the dose is route and dose also change. Here dose is 800 microgram. Sublingually route also change in treatment part, but in managed prevention part you have to 400 to 600 microgram oral misoprostol has to be given. Early use of intravenous tranexamic acid. Uterine massage also recommended. Massage is not recommended for prevention, but treatment you have to do massage. And for the use of tranexamic acid not recommended in prevention, but here you can use within 3 hours of birth. In addition to standard care is recommended for women with postpartum hemorrhage following vaginal or cesarean section. Always remember you have to use isotonic crystal, don't use colloid because that will cause more intravascular dehydrations. Standardized bundle approach. First line treatment postpartum hemorrhage should be included rapid institutional uterine drugs, uterine muscles, administered oxytocin agent, tranexamic acid, IV fluid, examination genital tract. Then administered uterine is recommended for the treatment of the retained placenta of vaginal birth only in the presence of postpartum hemorrhage. Routine antibody prophylaxis for manual removal of placenta has to be recommended. Very important, umbilical vein injection of oxytocin is recommended for the treatment of retained placenta only in the context of rigorous research. Treatment of refractory hemorrhage. If it is refractory, then recommended is temporary measure until appropriate care as bimanual uterine compressions. External uterine compression is recommended. Uterine tony non-pneumatic sock garment is recommended treating available. Then uterine balloon tamponade is used. Don't respond standard treatment like immediate You have to following conditions has to meet before going with balloon temporary: immediate surgical intervention, access of blood transfusions, primary postpartum hemorrhage like drugs, first line treatment protocol, uterotonic transaction, other cause of postpartum has uterine placenta trauma can be easily excluded. Procedure, health personnel will be trained, uterine balloon temporary, maternal regularly monitoring has to be done. Packing is not recommended. It is not recommended. If the other measure fail, uterine embolization is recommended for postpartum hemorrhage. If bleeding doesn't stop, treatment, massage, balloon dominant, then you go for a surgical cell salvage, recommended treatment post-hemorrhage in the country rigorous research. For women experiencing ongoing postpartum hemorrhage, initiating transfusion blood protocol should be based on underlying risk, continuous clinical and hematological assessment, clear protocol up to the use. Okay. Supportive care like oral iron supplementation 6 to 12 weeks following birth, IV same as oral therapies in pre-animal health system intervention like protocols. Okay, so these are the recommendation WHO 2025. This is a consolidated recommendation for the prevention, diagnosis and treatment of postpartum hemorrhage. So basically after read this guideline we can ask in the recent advanced questions. This is the FIGO International Confederation's Midwives World Health Organization consolidated guideline for the prevention, diagnosis, treatment of postpartum hemorrhage 2025. Okay, thank you. If you like this channel, please subscribe. Thank you.